Good evening, everybody. Welcome to our webinar tonight. We have Roy Shelburne, who, if you haven't heard him speak yet, I would definitely suggest the next time he's in your area or doing a conference virtually, like we were just talking about, you hop on and listen in. But hopefully tonight it's just an hour. I want to make sure we leave plenty of time for questions at the end. So, if you have questions, please type them into the Zoom Q&A section. We'll get to as many as we possibly can. I don't want to take up too much of everybody's time tonight, but Roy speaks on a topic that is near and dear to my heart: documentation, notes, systems within the dental office. I've read and heard a lot of things from Roy, take a lot of what I tell people in both our Facebook group and online and with my clients in general. And, unfortunately, I've used you as an example more than once. I know that you probably hear that a lot.
I'm the crash dummy. Yes, sir.
But I want to give you a couple minutes, let you tell everybody about yourself. I'm going to back out. I'm going to mute myself so you can have it. Tell everybody about yourself, a little bit of your story. The quick version, like you did with Howard, is a good start. And just for those of you who don't know you, and we'll get going.
Greg, thanks for the invitation. I'm a Southwest Virginia boy, born and raised. Set up my practice after graduating from dental school in 1981 in my grandfather's hardware store building. He and my grandmother passed away a couple of years before I graduated from dental school. Bought the building from my mom and her two sisters, lowered the roof, put the equipment underneath the floor, saw my first patient July the 27th of 1981 and practiced there with the biggest smile on my face for 27 years. Being as isolated as I was, CE was something you had to travel to. There wasn't a whole lot of local organizations. So in October the 24th of 2003, I'd flown to San Francisco, California to the American Dental Association meeting. It was in San Francisco that year. Rudolph Giuliani was a keynote speaker. 2 years after 9/11, of course, Giuliani was mayor of New York when the Twin Towers came down, and he was speaking on leadership. And I was there listening in that audience, so into what he was saying that my phone began to vibrate. I didn't notice it. The person next to me did. They elbowed me and they said, "I think your phone's vibrating." I opened the phone and it was my wife who was calling. I thought this was strange. She was visiting my daughter, who was at Virginia Tech at the time, wasn't home either. And I thought it may have been an error. She knew I was in this meeting and is not one to interrupt. So closed my phone, waited for Giuliani to finish. Everybody started to pour out of that large auditorium in California. Called my wife, and there was silence on the other end, dead silence when the phone connected. And I finally said, "Debbie, are you there?" And she said, "Roy, I am. Are you sitting down?" And I thought, this doesn't sound good. I asked her, I said, "Do I need to be sitting down?" She said, "Roy, you need to be sitting down." James had called. James was our custodian of the building. He had called her to let her know that the FBI had come to my office. They had battered down my back door and were taking all my records. Was not a good call. Talked to her for just a few minutes, trying to reassure her things were going to be fine, knowing that they probably weren't going to be, because the government doesn't do things like that unless they are hell bent on blood. So I hung up the phone with her. It was on Friday. Didn't expect any of my team to be home. Called my office. Didn't expect anybody to answer, but somebody did. The voice on the other end was like, "Hello." I said, "Hello, who is this?" I said, the voice asked, he said, "Who's this?" I said, "I'm Dr. Shelburne. I own the practice you're in and the phone you're talking on. Can you tell me what's going on?" And he introduced himself as an FBI agent and explained that I was a target of a healthcare fraud investigation. They had executed a search warrant and I was the target of that investigation. I asked him, did I need to be there? He said, no. I said, do I need to have an attorney? He said, I can't advise you. So hung up the phone, went back to the hotel, packed up my belongings, flew home. It was about 9 o'clock that evening, and passed my office, and it was surrounded by crime scene tape and a number of FBI vehicles. And I parked across the street for a short time, and I watched them carry boxes out of my office and into their vehicles. That search and seizure just happened to occur on our county's fall festival. There were parades through the town the next day and booths set up on the side of the highway. And guess what the topic of conversation was? That would be me and what was happening. My practice, as I said, was set up in my grandfather's hardware store building in the town that was the largest town in the county. The population of that town is 1,800. That's 1800. The population of the county is about 20,000. These were my neighbors. These were my friends that I treated. Was devastated. I actually thought the practice was going to be over because everybody knew. But one of the take homes for the people that are listening: if you have relationships with your patients, if they know who you are, if you have a relationship, it doesn't matter what's going on the outside, things will continue. Was investigated for the next 3 years. 3 years and 2 days after that search and seizure occurred, I'd come home from work. It was our early day. We started at 6:30 a.m., got done around 3 in the afternoon, went home, changed into sweats and a t-shirt, and there was a knock at my back door. That officer that I'd called and talked to when I was in California was at my back door, and he said, "Dr. Shelburne, I'm here to arrest you." He came with 7 other officers and 3 flatbed car haulers. I was charged with racketeering and money laundering in addition to healthcare fraud. So that allows the government to confiscate everything you own when you're arrested. So they pulled the vehicles out of the garage, they put them on the flatbeds, was being read my rights, had handcuffs on, a chain around my waist attached to the handcuffs so I couldn't raise or lower my hands any more than 2 or 3 inches, had leg irons on. The phone began to ring, and my wife, who was standing on my left shoulder with her right hand on my shoulder, turned to answer the phone, and the officer who was reading me my right stopped her and said, "Ms. Shelburne, we can't let you answer the phone. We can't let anything interrupt, so do not answer the phone." She turned back around, put her hand on my shoulder. The answering machine picked up, and it was my daughter, who was at the university at the time, calling. Tears. She was obviously very distraught, but through the tears, we could understand her to say, "Mom, Dad, they're taking my car. I don't need my car. Are you guys okay?" They could not only confiscate what we owned, but anything that I had supported in any way from the practice. So they took all the children's vehicles as well, took possession of all our bank accounts. Try to defend yourself with nothing. Was prepared for the trial. It happened in 2008, started in February, ended in March, 9 days. I learned a lot in the process of being investigated, preparing for the trial, and afterward about things that I should have done, could have done to protect myself. One of the things that I learned in the process was the definition of intent to defraud. I thought it meant if you submitted claims for patients you never saw for work that you never did, certainly that's fraud. But from a legal standpoint, it is much broader. It includes what's considered blind disregard, which means if you continue to make mistakes and don't have systems to identify those mistakes, that's intent to defraud. The investigation was for 6 years, and it was a Medicaid issue. Over the 6 years, I was paid $3.5 million for the services that I provided my Medicaid patients. And during the sentencing, the government established of the $3.5 million, the amount that I got that I wasn't entitled to. That amount of the $3.5 million was $17,899.57, which is 0.01% of the amount that I got, which I thought was a pretty good error percentage, but the government didn't. And even though we were able to go back over the same 6 years and do an assessment of the work that we had done, could have billed for and should have billed for and been paid for, it was in excess of that amount. It was about $30,000, but that made no difference. I was sentenced to 24 months in prison, spent 19 months in prison, 2 months in a halfway house, and I learned a lot in the process. I lost my license as a result of the conviction, was able to reapply in Virginia. The mandatory minimum period of revocation is 3 years. I was able to reapply July of 2011. The board met December 1st to deal with my request. I got my license back. I have worked very hard to learn about documentation, billing, and coding. I am very passionate about being the last dental professional who goes to prison for ignorance. I always thought if I got anything I wasn't entitled to, I could return it with any interest or penalties. Was never given that opportunity. The best opportunity I ever got to settle prior to going to trial was 3 years in prison and a restitution of $300,000. So I've become a subject matter expert for the American Dental Association on billing and coding, and I'm a coding documentation nerd. I didn't know how important it was, but I am on my soapbox early and often proclaiming to the rooftop that you can't ignore these things. And there's no such thing as an innocent mistake. You have to be careful about what you do, that claim form that you send to the insurance company is a legal document, and you will be held accountable for anything that is inaccurate on that claim form or in the clinical record that you cannot defend. So that, in a nutshell, is my life since the realization I was a target of a fraud investigation to today.
Well, your life to this point.
To this point.
So still a lot of it to go. But I mean, I can tell you one of the things, and I know you're in the group, so you probably see some of the things, but I know you're in a lot of groups, so you see a lot of posts. And one of the big questions, one of the big discussions we have is documentation, notes. We just had a big conversation the other day about x-rays.
Yes.
And x-rays being taken by order of the doctor or not by order of the doctor, having a standard. Every patient who walks in the door gets the same x-ray. What is your take on that?
Oh, I love this question because in addition to going to a lot of dental, as in dentists who provide care meetings, I also go to dental meetings where dentists who work for insurance companies also meet. Those are the consultants that work for the insurance companies. So I'm very well aware of the things that they discuss and find that we do inappropriately in dentistry. And x-rays are a huge issue. They've started limiting what they're going to pay. I do a lot of audits for practices, and sometimes when I'm looking at the clinical records, it says x-rays are not due. And my desire and hope is when I ask the person who made that notation what it means that x-rays are not due, that they're going to tell me that the doctor reviewed the patient's health history, some of the risk factors, and determined at this point the patient would not benefit from the radiographs. When I ask that question, the answer I always get, you probably know this, Rick, is the insurance will not pay for it now.
Right.
So x-rays are ordered because they are medically necessary, not based on anything that you're going to be reimbursed for, because your license will be based on the fact that you did what is considered reasonable. You meet the standard of care, regardless of what the insurance is going to pay for. So number one, they need to be medically necessary. If you need a document to give you a foundation, a baseline, the FDA and the ADA in 2008, they updated in 2012, did a multi-page document, I think it's 24 pages now, which actually includes a grid where patient's age, risk factors down one side, and it'll give you a box that suggests, in most instances, what x-rays are needed and why. You can deviate from that depending on the doctor's determination. And the doctor, hygienist, I love you, assistants, I love you. But the only individual who can determine the need for x-rays in a dental office is the doctor, because the hygienist cannot diagnose and put together a treatment plan, except in 2 states, Colorado and Oregon, and they have to have a certificate that allows them, has given them the right to be able to diagnose and do that, to practice independently. So in all the other states, the doctor has to make the determination those x-rays are necessary. So number one, determination the x-rays are necessary. The doctor orders them. Number two, they need to be adequately documented in the clinical record, exactly what was taken, and they need to meet standard of care. There was an issue with a doctor who reached out to me, was under an audit from an insurance company, had sent a PA to document the need for a crown to an insurance carrier. It was not a good PA. It didn't meet standard of care. It was overlapped. It was cut off. You didn't see the whole tooth. And the auditor, the consultant with the insurance company, looked at that x-ray and go, I wondered if they billed for this, and I wonder if they billed for other x-rays of similar quality. Wonder what we'll find. So the individual, this doctor, was actually audited. They pulled 20 charts. They reviewed all the radiographs that were taken during the 6-year period, because the statute of limitation of fraud is 6 years. So they went back for looked at these 20 patients. They found out that 22% of the radiographs that were taken and billed for did not meet the standard of care. They used the 22% number to multiply by the entire universe of x-rays they paid for during that 6-year period. They asked for 22% of all that back, and this doctor wrote a check back to the insurance company for $84,000. So number one, they're medically necessary. Number two, that they meet standard of care. And I encourage practices to add a code in their office that is a code that describes a non-diagnostic radiograph. So you need to track radiographs that we expose our patients to. And number two, it's a great learning opportunity. I'm never a big proponent of punishing people, but we need to be aware if we're doing it efficiently. And if you have an individual whose capture rate is 60%, 40% of them are not correct, then normally the doctor would never know. And, an example, patient comes in and patient complains of pain on the upper left-hand side. The doctor does a quick look-see, looks like number 15 is badly decayed, asks the assistant to take a PA. The first PA is taken, the assistant looks at it and goes, this isn't very good. And, asks the doctor, and the doctor says, no, go ahead and take another one. The second one's taken, and I know this doesn't happen in any place else in the country, but the second one was worse than the first one.
Never.
Assistant takes the third one, and it's perfect. In most cases, the doctor is never made aware of number one or number two. The doctor only sees the good one. But who does know? The assistant and
the patient.
And the patient, if you're firing a number of radiographs to get a good one, what is their perception of the ability of that individual who's taken the radiograph? So it's important that the office knows that rate, that they are taking poor x-rays. And it's, like I said, not an opportunity to punish, but it's an opportunity to understand there may be some learning that needs to be done. They need to maybe supply another positioning type system to be able to get a good radiograph. So full cycle, medically necessary, taken, and they meet the standard of care. And number three, the clinical record has to establish that the doctor reviewed them. Because unless it's in your clinical record, it didn't happen. And until a full service is completed, is it billable? And most plans, no. The incurred liability date for most services on the day that the service is completed. So the whole cycle is not completed unless they're determined medically necessary, that they do meet the standard of care, and that the doctor did review them. That should be the complete documentation in the clinical record to meet the standard set and to be able to bill appropriately for that radiograph.
Right.
So I'm sure I ruffled a few feathers there. You asked a question about having a standing protocol for your x-rays. Absolutely not. Are all your patients the same? The answer to that question, I hope, unless you're in an area where clone people, pretty regularly, no. Everybody's different. The situation that they they present with is different. You need to take into consideration that patients and their specific needs in order to prescribe the appropriate radiographs. And I see a lot of offices have some trouble getting their scaling and root planings paid when they've taken a Panorex and bite wings. Standard of care for a patient with perio issues with perio treatment would be a full mouth series, not a Panorex and bite wing. So if you're sending Panorex and bite wings in to justify the need for the scaling and root planing, that might be one of the roadblocks to getting it paid. You're not providing the carrier the documentation necessary to make that judgment whether or not they're going to pay for it, or to meet the standard of care that's established by most boards when it comes to providing patient care.
And that's a big thing. I mean, I fight with and struggle with and deal with insurance companies every single day. And one of the things I hear from not only my clients, but when I speak and, dentists and office managers across the country is it's these damn insurance companies.
Oh, you're the only one that fights with insurance companies. Everybody else is fine with it.
Right.
It must be something you're doing.
But people don't understand. I get, the insurance companies are incredibly frustrating. Yes. But so is not following the standard of care. And like you said, you need an FMX to diagnose perio. So how are you sending a pano with an SRP and saying I diagnosed perio?
Yeah, exactly.
That's like a ER doctor taking an x-ray of my leg and saying I have a broken arm.
Correct.
It doesn't work.
It doesn't work. And, are insurance companies bad people? No, they have protocols that they go by. It's not like they're picking on you because you're whoever you are. It's because they have a list of limitations and restrictions that they have to adhere to. You're not going to override them. It's kind of like if they have a 5-year limitation for a replacement of a tooth for any reason, you have to be concerned. I see a lot of people who said, well, I want to bill for a provisional and see how things heal. And I said, well, that's all well and fine, but you understand if you bill for the provisional and you get it paid, when the patient is stabilized and you're ready to go ahead and place that definitive prosthesis, they're not going to pay for it for 5 years. Right. So you jeopardize the patient's benefit for the provisional, when in fact they would get a greater benefit if they waited to do the definitive. And that's a discussion with the patient. So like I said, it's one of those things. Insurance companies have restrictions and limitations that you're not going to be able to get by. Are they good or bad? They are what they are. You just need to be able to understand that there are limits to what you can do.
Right. And it's like that with everything. And, I hope everybody understands that. But we got a couple questions here, and while we're on certain topics, I want to try and veer towards those questions. So first question that came in about X-rays is it the standard of care to take an FMX and not a pano for a new patient exam? What if the panoramic machine is old and does not take quality radiographs?
There again, standard of care. You have to meet the standard of care. And you can't say for every patient that comes in that you take a full mouth series. So if a patient presents complaining of a wisdom tooth issue, then it would be more than likely inappropriate to do the full mouth series. It might be more appropriate to use a Panorex to diagnose that. So you need to look at how the patient presents. And the help that I gave you, the FDA and the ADA, you can Google it as far as dental radiograph exposures. Those are guidelines. But understand that those are not hard and fast to be used for everybody. The patient's going to come in, they're going to have a chief complaint. You're going to do a visual evaluation. And from that information, determine at this point what x-rays would be most necessary to take a look at what the patient's issues are that are most pressing. Right. So there are complaints or things that are going on that will supersede what's considered normal. The standard of care may be a patient who presents this way, you take these ones, but a patient that presents this way with this complaint, and the doctor has an idea of what they might be looking at, you would use the x-rays that would help to diagnose definitively that thing that the patient is complaining of or how they present.
And that's another reason why it's important for doctors to stay current, and why, I mean, we both speak at events, we both do CE events across the country, and I see a lot, the dentists in the back of the room, the assistants and the hygienists and the office managers at the front, and the dentists are in the back and they're reading their newspaper and they're looking on their phone. You know, don't look at continuing education as something you have to put in the time to keep your license. Look at it as an opportunity to actually learn something,
Of course,
because,
out of prison.
well, that too, that's important. I know I don't look good in orange, so
I didn't either.
but you know, use it as a time to actually learn, because things have changed since you graduated dental school in 1975 or 1985 or 2015.
Yeah. And
Things
Rick,
have changed.
I'm sure you'll be able to say things have changed in the last 5 to 10 years at a greater rate than the previous 40.
Right.
And that will continue to accelerate because of the technology we have, the ability to be able to do more than we ever did before using what we have. When I graduated from dental school in 1981, we didn't even wear gloves to see patients. We might if we were doing surgery. Otherwise, never wore gloves. And that was in dental school as well. That wasn't like a decision I was going to shortcut when I went into dental practice. In the clinic and when I was at VCU, it was not required. So just one example how things have changed. There was no HIPAA, there was no OSHA. I could literally have made every single mistake, and probably did, when I opened my practice, and still was successful. If you do that today, you could lose your license by one single mistake and go to prison for another. So like I said, things have changed.
Right. Absolutely. So one of the other questions, we're getting this one a lot, is charging for x-rays. So like you said, first of all, in order to charge for it, they have to be diagnostic quality. They have to be a diagnostic x-ray. If you take a PA and you miss the root tip, it's not diagnostic. And I love the idea of having an admin code in the software to track that. Like you said, not to get people in trouble, but all of business is identifying areas of improvement.
Correct.
And looking for places where we can train people to do a better job.
And another one of those, I'm sure this never had happened in any other office but mine, but occasionally we would have patients refuse radiographs. And that was one of two reasons, generally. One, they didn't want to pay for them. And number two, that they were afraid of the radiation. And I'm just going to throw this out here for you. If you have a patient that's been there for a long time and you have an assistant that has to take 3 films to get one that's good, and they're going to have 14 to 16 films taken, patients can do the math. They're going to be able to determine how many exposures they're going to actually have if they're going to have to take 5 to get one. So there again, the more efficient we are at being able to take those radiographs, the better we look in the patient's view. These people are dead on. They get it right every single time. So just another thing to think about.
Right. And that was one of the questions here, was taking those x-rays and charging out for them. If somebody takes a PA and a bite wing with a limited exam,
yes,
charges $0 for the bite wings, do they still send it on the claim? And I will say, if you're in network, the vast majority of your contracts say, if you do something, there is a CDT code for you, send it.
Correct.
Will that trigger the bite wing frequency, even though you did it for free? It might. It probably will.
I can tell you it might. I tell you it absolutely will. They'll track it with zero money. So that patient's not going to be able to have a bite wing that's paid for in 2, 3, whatever the limitation period is. And I'm going to get a little jinky here with you. There is a way not to have to submit that to the insurance. So HIPAA trumps your contractual agreement with the insurance carrier. So if
Absolutely.
the patient signs an agreement that says, do not submit, you would violate HIPAA, which would trump the state regulation or the regulation with the insurance to send that in. So if the patient says, no, do not send this to the insurance, don't want you to do that, you cannot.
Right.
The
But
patient has,
and
go ahead.
we've talked about that HIPAA disclosure restriction a number of times in the group. There's one uploaded in the group files. There is one on the resources page of our website, but you have to remember that comes with some caveats, one of which is the patient has to pay for it in order for that to be enacted, because if they didn't, now it looks as though you're using an insurance discount while not submitting to insurance. So you're only enjoying the benefit of the contract and not the downfall of it.
And I'm sure you've discussed this as well, but for that patient who on the weekend got number 9 knocked out, they don't want to go for 6 months having no central incisor. So you make a flipper to get them through the aesthetic issues until you can do something definitive.
Right.
If that contract, and you're right, Rick, the majority of the ones that you're in network with will mandate that you submit everything, paid or not. But if it has a CDT code, you are obligated to send that in unless the patient does tell you not to. So for a patient who has that flipper, the discussion with the patient is, oh, Mrs. Smith, I can go ahead and send this into your insurance. With a flipper, they're going to pay $250, but they're not going to pay for anything else to replace this tooth for 5 years. Would you rather maintain that benefit for the implant, the bridge, whatever you're going to do for them? And it's probably going to be $1,500, whereas you're going to get $250 for this and nothing for the other. And I love the statistics. Like I said, I have ADHD, so I'm going to chase this rabbit. I hope you don't mind.
Nope.
Why has the insurance maximum that the insurance have established on those plans changed? Never.
I'm going to let you tell it, but just as a side note, I just did a drive live for those of you who know what that is. Every morning as I'm driving to my office, I do an 8 or 9 minute Facebook live. I don't look at the phone. I don't look at the screen, and we talk about a different topic every day. And I talked about this on not this week, but one of last week's live events. But go ahead and spill it.
Of the people in the United States who are covered with dental benefits, what percentage of those actually hit the maximum per year? What percentage of all those insured actually use their maximum? The last data I got from the NADP was 7%.
It went down.
It was 12, it went to 7.
Wow.
Of the people with dental insurance, only 7% use the maximum. And the insurance company pointed this, only 7% of our insured use it. So why in the world do we have to increase it?
And unfortunately, or fortunately, you have to remember insurance companies are a business. They exist to make money. Even the nonprofit organizations that are insurance companies exist to make money.
And they use actuarial tables, submissions to be able to set that price at a point where they know they're going to make money because the history of submissions have been at this level. So they feel comfortable at pricing at this level because they know that that's going to make it work, and how to price that to the insured.
Right, exactly. So, all right, so let's see here. We answered that one. Can you take an FMX and a PAN on a new patient and only charge for one out of network office?
Absolutely.
Absolutely. You're out of network. You do what you want. However, if you're going to submit the claim for the patient, if you're only charging for one, make sure the claim form says you are only charging for one. Make
Correct.
sure one of them is zeroed out. Because
and if you're in network, you can do the same thing, but understand it's not going to get paid.
Absolutely. And that's the key. And we talk about that a lot in the group.
Mm-hmm. And if you're in network, what they do is accumulating submissions of radiographs. So if you hit the FMX number, then they cut it off. They say, okay, we're not going to pay for any more radiographs because we've done this FMX level of reimbursement. So you're not going to get any more until the limitation period drops again.
Right.
So just be aware, if you take, vertical bite wings and maybe a couple of PAs, and all those submissions come up to what that plan has established as an FMX, they're going to draw the line, say, we're not going to pay any more after this. Now, that doesn't mean you shouldn't take them, because there again, patients, they need to be treated appropriately, not by what the insurance is going to pay for.
Right. And that kind of brings us to the next question, talking about, appropriateness. And this was another big discussion in the group that we just had the other night. Is it true the doctor should see the patient first to diagnose what radiographs are needed, and not just walk in the door and the DA automatically takes them every single time?
Not necessarily. Okay, so depends on the practice, but the doctor has a patient in the chair, does the exam, does the evaluation, evaluates the patient's history, and goes, Mrs. Smith, at this point, I don't think we need to take any radiographs, but taking in consideration your risk factors and what I'm seeing here, I'm going to recommend that we take them next time. So the doctor has teed that up, has made the order for the next visit. So do not necessarily have to see the patient. No, but without any interaction at all of the doctor having evaluated that patient in a way that they would feel comfortable supporting it if they were in a malpractice action, the doctor can make that order without having to have hands on the patient. Patient can be in the chair, have an emergency, give the assistant or hygienist has talked with the patient, got their chief complaint, and have done an evaluation from their point of view. They've assessed or have taken a look at the patient. They convey that to the doctor. The doctor can then, if he feels or she feels has enough information to order a PA before they're going to be able to make the diagnosis, yes, they can do that. So like I said, does the doctor have to have hands-on? Not necessarily, but the doctor needs to be actively involved in the determination of the need for those radiographs and make that decision based in a way that would make sense to another subsequent treating doctor.
So it never should be new patient walks in the door, I'm having a terrible toothache right here. The assistant says, have a seat, opens their mouth, takes a look, takes an x-ray, and then goes to the doctor and says, hey, new patient in chair 2. I took a PA on number 5.
Nope.
Take a look at it.
Most efficient offices in situations like that, when you have a emergency patient teed up, that would be a discussion at the morning huddle. And there again, if the doctor feels comfortable that they've gotten enough information about that patient, chief complaint, some of the supportive information, and that's all systems in your office. So if a patient comes in with a complaint, the doctor should have a questionnaire that front desk person goes through and asks the question that the doctor will need to make the necessary radiograph recommendations for that patient. Blindly, absolutely not, but with enough information set up with systems in your practice, can that be teed up beforehand? It absolutely can.
Okay. So we got a lot of questions about x-rays. So we're going to move on in a minute, but I'm going to ask a couple more here.
I'm not surprised.
So these are very similar. Can you take an x-ray when seating a crown to make sure it's seated properly and charge for it? And what about after crown placement? Should they be taken every time?
So the radiograph taken to diagnose the tooth prior to treatment, yes, can be billed for. Anything that you take in the interim to make sure that your crown was seated appropriately, that is part of the crown treatment. Same thing with x-rays during endodontic treatment. That's all considered part of that service for providing the crown. So following up with subsequent crowns or subsequent x-rays at subsequent visits, just to check to see if the tooth is doing okay, there would be no way that that could be justified from a exposure standpoint for the patient unless there was an issue with the crown that you needed to be able to see and diagnose. So through the course of treatment and as an assessment of the fit of the crown, that's included in the crown. The diagnosis beforehand, that can be billed, and then subsequent diagnosis afterward, and it's generally 6 months or longer unless the patient comes in with a complaint, can you take a PA then to be able to diagnose sensitivity or something like that? Yes, that would be to diagnose. It wouldn't be to provide the care for the crown. So that answered that question. Was there a second part on that as well?
Should an X-ray be taken at every crown seat?
Yes.
There you go. There you go. And I just want to throw this out. I mean, I'm not Roy. I'm not a dentist. I never have been, and I don't want to be. I married one once by accident, and I won't do it again. However, I have been saying for years, even before I ever met or heard of Roy, don't write your notes. Don't do your documentation for you. Don't do it for your malpractice insurance. Don't do it for the patients who are going to read it when they request a copy of the record. Write your notes and do your documentation for the jury who's reading it 5 years from now.
Absolutely.
That's who you're writing your notes for. The normal layperson who has no idea what dentistry is. Yes, you're going to use terms they don't understand, but they have to be able to see you did the right thing.
I can tell you in my experience, from the malpractice point of view, a patient goes to an attorney, they feel like they've been damaged. The first thing the attorney is going to do is ask for your clinical records. And I can tell you, if that attorney gets a clinical record from a doctor that meets all the standards, they hit all the high points, everything is there, that is an uphill climb. They will not take that case because it's going to be almost impossible to prove. If you leave anything open to interpretation in that clinical record, that is an open spot for them to be able to develop a story that is different from what the doctor's story is, because the doctor has one tale, the patient has another tale, and the determining factor will be what that doctor documented about that will support his position and refute any allegation the patient's making. Right. So that is your best malpractice insurance. You should have malpractice insurance, absolutely, but this will be an insurance that you will not be named in an action because it's indefensible. The position of your patient is indefensible because it's all there in black and white, very obvious why you did it, what you did, the outcomes, it's all there. They're not going to work through that. It's too hard.
Right. And I'll tell you, we just had to drop one of our remote billing clients, and it was a big one. It was a big client, $3-4 million a year practice that we had to drop because their notes were crown prep number 6, 2 carps lidocaine 2%, patient tolerated procedure well, next visit, delivery.
Yeah. Reader's Digest condensed version that you could inject any storyline in the middle of that and it could be plausible.
Right. You have to say why. Why are you doing the crown? Why are you doing the root canal? Why are you doing this?
Yeah.
That's what it comes down to.
Yeah. And we in dentistry are horrible at documenting diagnosis. And we're going to get what we want. We want to be not just dentists, we want to be part of the medical community. And if my crystal ball works correctly and what I'm seeing in the insurance industry, we're moving toward medical billing. So that dental billing, I think, will at some point in the next 10 years be set aside and we'll all be using medical coding with diagnosis codes and then treatment codes. It's inevitable.
Yeah.
And the reason for that is insurance companies are all about what? The money. So how much more expensive is it to have 2 different tracks for insurance claim processing, a medical and a dental? So if we could combine them together, we would have half as much to do. Right. So like I said, if you want to follow the money, my crystal ball says that in the next 10 years, dental coding, dental billing, separate from medical, will not be non-existent.
Right. I agree. I've been telling people for a little while now that's what's going to happen. There's 2 separate departments, and I will say, the people answering the phone on the dental side of it 6 months ago worked at the gas company, and a year from now are going to work at the cable company, and they don't know.
They don't. You call a company and ask the same question to 3 different representatives. How many different answers do you get?
4.
Yeah. One of them will go, oh no, in the middle of it, I don't think that's, wait, try this.
Exactly. That's the way it's going to work. So, all right. So here we go. Last one on X-rays. Another seminar said we could bill for the X-ray taken at the seat appointment. So now Chief Boss is hell-bent on taking and charging. Where can I find this in writing that it should be included in the crown fee, since insurance does seem to be paying for it?
Sure. That would be a question. It would typically, they would look at the X-ray on the seat date. Are you billing on seat date or prep date? Because that would look like it would be something that you would be using after the seat, but that's a whole nother story. I would go to the state association, and usually they will have a individual there who is well versed in dental billing and coding. If not, you can go to the ADA, and if you're a member there, they will transfer you to say I have a billing coding question, and they will send you to that area and ask that question. I can tell you from the insurance point of view, if you bill for that X-ray at seat date, it's considered unbundling, which you have taken something out that should be included in the service and billed separately for it. And that is a fraudulent act by definition, unbundling.
Right.
They define that as unbundling. When you take a service out, bill separately for it when it should be part of the service, the global service that you're providing.
There you go.
And X-rays are one of those that insurance companies do identify as a common item that is unbundled.
Right. So, all right, one more, because this one's hit 6 or 7 times now. Patients refusing X-rays.
Oh, let's go there.
Hot topic every day. It has been for 100 years. I personally, 10 years ago, when I started speaking, I'll put it to you this way. I have changed my view in the past 10 years. But what would your recommendation be?
If the doctor needs the radiograph to meet standard of care, you cannot give the patient your license to practice dentistry. Basically what you're saying, if the patient says, I don't want radiographs, don't take them, I'll sign this document that says I understand their risks. Basically what you're doing is saying, okay, you're the doctor, I'm going to do what you tell me to do because you don't want that done. So you have 2 things you can do here. Patients don't want X-rays because they don't want to pay for them. If you need them, you want to have the patient, you don't want to ruffle the feathers, you can do it for free, or you can dismiss your patient if it's a money issue. The other, I encourage you, if it's a radiation type issue, I would look to find out what the exposure is and transfer that into an everyday exposure that they may have to sunlight or whatever that might be, so that they understand that in fact, the exposure that used to be 10 years ago before digital radiographs, I can understand there was an issue back then, but today the doctor is very concerned about exposure, would never order a radiograph unless absolutely necessary to protect you, take good care of you, and to save you money by diagnosing early. And, are there patients going to push back? Yes. What 2 things about people can you not fix? There are 2 things about people you can't fix.
Stupid.
And crazy. That's the second thing, stupid and crazy. So 10% of your patients are one or both. So that patient who refuses X-rays, is that a good patient who will typically sit and go, I don't want the X-rays, but I do want to accept all the treatment that you've suggested to me? That's the patient that says, I only want what the insurance will pay for, and I don't want anything else. Like I said, you need to decide, do you want to risk your license? Do you want to put the practice in jeopardy by caving to the patient's wishes, or do you prefer to meet the standard of care and treat patients appropriately based on what their needs are, not caving to what they want?
Right.
How many times do you have a patient, same thing, I don't want scaling and root planing, I just want a prophy. I want the free cleaning my insurance is going to give me. When they have mobile teeth and they have bleeding areas and they have draining everywhere. So like I said, they cannot defer by signing a document that says, I don't want X-rays, and the doctor is not in jeopardy of having an issue. So if that patient's gone down the street in 2 weeks and they have better verbal skills, And the doctor caved to the patient, hadn't taken any x-rays for 3 years, and all of a sudden they go to this other dentist and find there's periodontal disease that is very significant, or they have an area that's of a tooth that's decayed and is about to abscess. Doctors, that's on you. That's a malpractice claim for failure to diagnose. And even though the patient signed that document that said, I don't want x-rays taken, the burden is still on you. You have to follow what you as a clinician have been taught and understand to be the right thing to do. If you ever defer to the patient and not do the right thing, you can be in trouble even if they direct you to.
Right. And I will say 6 years ago, I had this fight with a dentist I was very, very close to. I won't say that was the reason for the divorce, but it was a big fight between the two of us. And I finally said, you know what? You want a refusal form? That's fine. I'll call your malpractice carrier and I will ask them to send us one. They sent us our consent. I called the malpractice carrier, spoke with one of the people there. After working my way through 3 or 4 people, finally somebody came on the phone and said, sir, we don't provide those because every time a refusal form has been signed by a patient, it was used to prove their case in the malpractice suit. It doesn't help the dentist.
No, I was starting to say, you talked to the malpractice, and I was thinking, there's surely not a malpractice company that would give you that form and suggest that you use it. Or if they do, run screaming from the building, because that's crazy. Any attorney that you talk to, hey, they love those, where the patients sign the document and go, hey, this happened after the fact, and no grounds to stand on.
Right. Now, so getting away from X-rays a little bit, there's a couple people that had questions more relating to your story.
Okay.
The first question here was a couple people asked, did anything happen to anyone else in your office? Was anyone else held responsible? Did anyone else have to testify or anything?
I was the only one held accountable and responsible. My team they testified. And in fact, they asked my business person, did you ever make Dr. Shelburne aware of any patients that you received and processed that you thought were inappropriate? And her answer was, no, I did not. So did they testify? They did. But there again, it was blind disregard. The question also was, what was the office policy as far as reimbursements, as far as auditing the payments, the EOBs, to make sure that they were done correctly? And the response was, we didn't have any. So that's blind disregard. I didn't have any systems to identify and correct errors. So that's considered, from a legal standpoint, intent to defraud. There have been, I'm aware of an oral surgeon in Texas who did not have a facility of his own. He actually rotated through 6 facilities in the Dallas-Fort Worth area. They indicted him for healthcare fraud. They indicted his chairside assistant and his main business manager for healthcare fraud. And they also indicted the 6 doctors who provided space for him to practice. In this specific instance, the 2 team members, they removed the indictment against them in exchange for, wait for it, their testimony against the doctor.
Right.
And then the 6 doctors who they named in an action, they removed the indictment against them. And by the way, one of them was a state senator in Texas, so it doesn't matter who you are. They removed the indictment against them 2 weeks before it went to trial. And I understand the least any of them paid to prepare for and pay an attorney and the expert witness prior to was $300,000. Now, this doctor was found innocent of the criminal charges, but now lives in fear of being charged civilly. Just like OJ, you can be charged criminally and civilly.
Right.
Oh, by the way, month before I was released from prison, I was called to the administrator's office and I was served with papers. I was also charged civilly after having served my criminal charges, my criminal prosecution.
Wow.
So yeah, guns a-blazing.
Wow. So, I mean, it was nice that they waited until he only had a month left to.
Yeah. So when I left, I couldn't relax. I had this hanging over my head.
Right. But that's our tax dollars at work.
Yeah, exactly.
But all right. So there's that. I will say, like you said, office managers being seen as complacent, being seen as accessories. The vast majority of the time, if there are charges levied, it's a play to get you to testify. We'll drop this if you testify against him because he's the big, mean, evil guy.
As in my case, I was charged with racketeering and money laundering, and that allows the government to charge anybody who got any type of reimbursement from the practice. So they could have named everybody from my business manager all the way down to the custodian.
Right.
Everybody could have been named. Anybody who
your billing company sending your claims for you.
This is true.
And people wonder why I'm very, not quick, but prudent about this is what we're going to do. Oh, well, if insurance doesn't pay, write it off. I'm not doing that. I'm not.
No, you actually need to be aware of the fact that you're providing a service to them. You know, I wished I had somebody who had looked at my claims and given feedback and said, oh, by the way, this was a mistake you need to be aware of and need to implement them and understand that you can't do this moving forward, that we need to correct this and you need to be aware. I would have loved to have had a guardian angel on my shoulder saying, oh, by the way, you need to look at this. That's not a bad thing. That is an excellent thing.
Right, exactly. All right, so next question, we'll get back to insurance, away from x-rays, thank goodness. If you receive an overpayment, is it legal to just sit on it and keep the money until the insurance company requests it back? Or if you know it's an overpayment, should you notify them or just sit on it for 2 years?
Well, number one, you need to make sure that it's an overpayment. And in my experience, that is so infinitesimally rare. I see it happen occasionally when there is a supplemental plan like Aflac. They'll pay and then you're going to get a negative balance. So depends on system set up in your office. If the patient in the financials, if there's a section there, if in the event you have a true overpayment, would you like this returned or would you like this held on your account for future treatment? You can keep the money then because you've been directed by that patient. If not, there are regulations in every state that require you, depending on the period, some 1 year, some 2 years, you have to return that money to the state and they put it in a unclaimed property till. So you have to go to your state and Google it, unclaimed property, how long you are allowed to hang on to that negative balance. And at the end of that period, you either, if you don't have the designation from the patient that you should keep it for future treatment, they've ordered you to keep it, then you're fine. But if not, then you have to assume that's in effect. And you try to contact the patient, and the patient, then you send the money to them if it is true. And I would always get them to sign a document that says, in the event that the insurance determines this was an overpayment, I will be responsible for returning that money to the carrier or to you, so that you're covered that way. Because how many times 5 years after you've submitted the claim, the insurance goes, oops, we made a payment that we weren't supposed to. So have the patient sign that. Or if you can't locate the patient, then you need to invoke the unclaimed property, follow the statute, and return that money to the state. So if a patient should 15 years later say, well, we followed state regulations, we had to give it to the state, you need to contact the state, they can return it to you.
Side note on that unclaimed property thing, check it for your state. I just checked mine a month ago. I saw a billboard that said, I mean, I knew the laws existed, but I never checked for my own name. You know, I've told dental offices across the country, credit balances have to go to the state after 12 months, 18 months, 24 months, depending on your state.
Whatever that might be.
Went to the website, typed in my name. There was an $860 check that I never cashed when I was 26 years old.
There you go.
Turned over to the unclaimed property division of the state of Pennsylvania. And I just got the check last week. And there was no interest, of course. The state kept that.
Of course not. Of course not.
I got $860.
There was interest, but it didn't go to you.
Exactly. I didn't get it.
Yeah.
So, all right. So what do you do if you're the biller and your boss is in network with a carrier but demands you charge more than the contracted rate for Invisalign, even though the insurance doesn't allow an upgrade. You
Yeah.
know you're violating the contract by doing it, but your boss tells you do it anyway.
You contact the boss and provide them with your concerns and give them an opportunity to correct it. In the event that the boss goes, nope, not going to do it, you need to think very long and hard about how you might be a part of the action and whether or not it's worth it. You know, I encourage, I'm not one that would suggest you walk away, but you're at risk and you need to determine whether or not I would certainly make notation of all your efforts to make the doctor aware and to change the process. That might take a little bit of the spotlight off you because you intended to do what right, but the argument would be, well, you just stayed around anyway. So in that way, you're condoning it by not standing up anymore or not leaving. So like I said, that would help you a little bit, but if you have a prosecutor that is rabid and wants you, they will get you.
Right. Exactly. And you don't, the last thing you want to be is complacent.
Correct.
That's
If you're
the
aware
last
of
place.
it and you obviously you have probably told more than one person about it, they will know that you are aware of it and yet did nothing to separate yourself from the situation.
Right. Yeah, if you're walking around with a "because Rick said so" hashtag shirt on, and the DA walks in and says, "Did you know you weren't allowed to do this?" You can't say no, because they know you did.
Yeah.
So, all right. Looking for the next question. Here we go. This, I get this all the time. I will appreciate someone else answering it other than me.
Good.
You're doing a crown for a patient. The dentist says, just accept what insurance pays. Bill it out normal. Just take the insurance check right off the patient portion.
Waiving copays and deductibles without proper notification of that instance, the insurance carrier, is illegal in every state and considered unethical by the American Dental Association, period.
There you go. But wait, what if I write in the remarks section of the claim form, patient is not sharing in copay?
Depends on the service you're providing. If it's auto adjudicated, which means, for example, if it's a restorative procedure or it's whatever it is that does not have to be processed by the insurance, that is divulged in a way that it will never be reviewed. Those are auto adjudicated. The insurance company will not have been made aware of the practice in a way that they would be have knowledge of that situation. If you notify the insurance company in a way that they are aware, and that would be, if it's auto adjudicated, send it as a paper claim or send it with an attachment. Those automatically drop out and somebody has to review those. That's disclosed in a way that the insurance company is going to be aware of them. But understand, if you do that with any frequency at all, the insurance company is going to go, I wonder how and why they're doing all this. And if you don't think they keep eye on all the insurance, all the practices, they absolutely do. There's no such thing as a random audit in my experience. Like I said, getting behind the curtain with the insurance companies, that could very well trigger an audit and then a focus review, so that your life will never be the same again. And you have to determine whether it's worth it to risk that. Insurance companies, the only thing that they share among one another is their submission frequencies. And P&R Strategies is a company where the insurance companies send all their data, their submissions to. They crunch the numbers and it develops a bell curve of averages. And Dr. Average, you're right in the middle. You don't do any more, any less than anybody else. But if you start moving one or two standard deviations out, that increases the risk of audit because you're doing something funky that your neighbors are not doing. So like I said, Big Brother is looking at those frequencies all the time to determine, okay, who's out of considered normal and who do we need to focus on? And that can trigger an audit. So anything you do like that that's a little bit on the funky side, that's going to move you to the top of the pile and goes, we need to take a look at this doctor.
Yeah. And for anybody who doesn't think insurance companies are looking at the numbers, watch the Facebook groups with the dentists who get a letter from MetLife saying the average dentist does 4 or more surface fillings on 7% of the patients they see. You did it on 7.2%. We just want to let you know you're at 7.2 when the average is 7.
Right.
Those letters are posted all the time.
Yeah.
They're watching, and that little of a difference.
How many doctors have posted letters that say, oh, by the way, you're doing 7% fewer core buildups than the other guys, so we just thought we'd let you know.
None.
If you ever get one of those, please frame it and send it to me, Rick. I'd love to see one of those.
I would love to see one of those as well. So let's while we're on discounts, well, here, this next one, out of network office gives, say, 10% discount on a procedure, submits claim for the patient to receive reimbursement. Do we need to tell insurance about the discount? If yes, how? Yes, you do. In or out of network.
Submit the fee that you've agreed with the patient to accept as payment in full. So if you're giving a 10% discount, your crown's $1,000. Normally, you submit on the insurance form $900 because that is your true fee for the service for that patient. Period.
Right. And
that
whether you're
form is accurate. So if you've agreed with the patient to accept that as payment in full, that's the fee you've charged the patient.
Right. And whether you're in or out of network, misrepresenting any information on that claim form is fraudulent. The network contract doesn't make a difference.
Does not.
It's what you put on the claim form, and that's what matters. So you're giving a discount to the patient. The amount you intend to collect is the amount you put on the claim form always. So that's perfect. There was one other question that I wanted to get to. Somebody's doing an audit. Okay, so I'm doing an audit for a practice. Today I noticed EOBs for payments from Medicaid, and there were no patients by that name. I called the insurance company for missing payment, and it had cleared the insurance company's bank, but was not on any patient's ledger. How do I bring this to the doctor's attention? I suspect it's someone in the office, but not the doctor. However, I want to remain anonymous.
You want to remain anonymous?
Well, first of all, you're auditing a dental office.
Anonymous to the doctor.
You're not going to be able to remain anonymous to the doctor because you have to let them know. But if you have found payments made to the practice that were not cashed by the practice, you don't want to be anonymous. You want to let the doctor know, let the police know. You're going to be called to testify. We're prepping for myself and my vice president of operations, prepping to testify in Connecticut in the next few months over this because we found somebody changed the bank account on EFTs. They were closing the claims. Doctor never saw it. There was no checks and balances. We took over. We find.
If you're doing an audit for the doctor, your responsibility is to make the doctor aware of anything that you found. Errors and omissions, not going to cover you if that's intentional. So being anonymous, you don't have to say I found fraud, but when you disclose the information to the doctor, just give them factually, this is what I found, looked in the ledger or looked in the software system. There's no patient by that name. There is this payment to you, but there's no patient, there's no deposit, and I find this interesting. Here you go.
Right. Now, just devil's advocate here. What if you report it to the doctor and the doctor says, yeah, don't worry about that. I know what that is. Don't worry. And now you're even more concerned because it's the doctor who could be committing that fraud.
That is a legal question that I would not attempt to answer. That's for an attorney to say what you do with it. I'm not an attorney. I can't give you legal advice. So this is where I step back and go, that's an attorney. I cannot recommend because that is a legal issue and I do not have an attorney license, thank God.
Right. I will tell you, I have, I'm not a doctor. I have malpractice insurance. I have errors and omissions insurance. I have business insurance. If I have a question, I call them.
Yeah,
they will tell me.
They have attorneys that will intervene on your behalf. They pay the
Exactly.
attorney. You don't have to. So
Right.
absolutely.
Because if I call Medicare or I call Medicaid and I report that dentist as being fraudulent and $300,000 in attorney's fees later, he's found innocent, now he can come after me for turning him in. So I want to let my insurance company know in advance and they will guide me on how to do it.
Absolutely. And then
I,
be liable to pay it. You will not be, because you did something you weren't supposed to.
right. Absolutely. So contact them. Well, I'm gonna take, we still have a bunch of questions. I'm gonna print them out. What I'm gonna do, everybody, I'm gonna print these questions out. I'm gonna copy them in. I don't want to keep Roy all night. It's been a long day. It's Tuesday and it's been a long week for all of us already. It's January 19th and it's been a long year. So um, I'm going to take all these questions. I'm going to email them over to Roy as he has time. Hopefully he can respond to some. I'll answer the ones that I know. I mean, you guys know I know everything anyway, but we'll send them over. We'll get, we'll do Rick's response, Roy's response on as many as we can. I'll make sure to post those in the group. I'll also post them on my Facebook page, and I'll put a link to the PDF of the answers on the video of this that will be on YouTube. So, again, Roy, thank you so much for coming on. This was
Pleasure.
excellent. We got a ton of questions. Anybody that has questions that would like to contact you, what's the best way for them to get in touch with you?
Email. It's my name, or you go to my website. It's just Google Roy Shelburne Dentist, and there'll be a contact link there. Just go ahead and enter your information with a question. Be happy to respond that way.
Perfect.
Yeah.
Well, again, I appreciate it. The replay will be up on YouTube. I'll make sure to post the links on Facebook and emailed out to all the registered attendees of the Zoom conference once it's up and ready to go. So, thanks again, everybody. We'll get those questions. Roy, thank you very much. Everybody have a wonderful week. Finish the week strong and look forward to seeing you guys again next time. And Roy, I'll see you hopefully one day live again in person in a speaker's lounge in some far, far away land.
Hopefully the Caribbean.
That would be good. But thanks, everybody. Have a great one.